giants, one of the great giants of and pioneers of palliative care, passed away a few days ago, Dr. Robert Twycross, and Moira Ling, who's on our executive, she knew him well. And so we're just going to spend a few moments acknowledging the great work and the great person that Robert Twycross was. So Moira, over to you, please.
Thanks so much, Joan. I mean, for some of you, Robert's name will be a name you've seen on textbooks, and others it will be somebody who you knew well. But Robert had a 50-year career in palliative care, and starting as the first clinical research fellow with Dame Cicely Saunders in London. And he had a particular interest in pharmacology, and a lot of what we take for granted now in terms of how we use oral morphine, the research was done by Robert and his colleagues. He also started palliativedrugs.com, the whole formulary for palliative care, which continues with others now leading it. Crucially, internationally, he started and was the founder of and director of the WHO Collaborating Centre in Oxford at Michael Sobel House. And that was a place that nurtured what became the leaders of palliative care in many parts of the world. And we think today particularly of people like Emma Rajgopal and others who first learnt together with Robert. He has worked in over 50 countries. And I know he had a particular heart for mentoring and seeing people grow, and was a real stickler for getting things right. He had ran a course called Advances in Therapeutics, and he really pushed us to make sure that what we were doing was based on evidence and quality. He was a man of faith and a deep conviction of the equality of everybody and of the importance of holistic care being available to whoever was in need. And so we remember him, and we stand on the shoulders of giants like him as we continue in the work of Palchase and the work of palliative care globally.
Thank you so much, Moira. And so I invite us now, as we begin this webinar, just to pause in silence in remembering this great pioneer. May he rest in peace. May his memory always be a blessing. Amen.
Amen. And thank you so much, Lord, and Father Rick. And so welcome, everyone. This webinar will be recorded and available on the Palchase website in a little while. And it will be repeated tomorrow morning, well, 8 o'clock London time, UK time, for those who could not attend at this time. And so it gives me great pleasure. As a member of the executive, my name is Joan Marston. I've been with Palchase from the beginning, and together with Father Rick, we are responsible for advocacy. And it's my pleasure today to facilitate this meeting. And so I'm going to introduce both of our speakers and then our panelists a bit later on. And so our first speaker is Dr. Roberta Ortiz, originally from Nicaragua, but at present she's working as the medical officer in the Global Initiative for Childhood Cancer at the World Health Organization in the Department of NCDs. And of course, this is so important in palliative care. And Roberta has done a great deal of work, not only in her own country, but also across Latin America in developing pediatric palliative care and guidelines. And so we are delighted to have her here to give a global overview of palliative care in humanitarian settings. And then after that, we have a dear friend, Smuti Rana, who heads the WHO Collaborating Centre for Training and Policy on Access to Pain Relief at Pallium India in Trivandrum. She also heads the Strategic Programs and Partnership Division, and she is a very active advocate for access to opioids and to pain relief across the world. And we will have their bios up on the website where you can read more about them. And so with that, I'm going to hand over to Roberta, And we look forward to hearing you speak today on the global picture. Thank you.
Thank you so much, Joan. And also would like to thank Moira and Erin for giving me the opportunity to share with you today this presentation on the work that we're doing at a global level to advance integration of palliative care into humanitarian settings. So as Joan has mentioned, the scope of my presentation is to present a high-level overview on the efforts that the World Health Organization, in collaboration with partners, is leading to integrate non-communicable diseases and particularly palliative care into the global humanitarian response. So you can see here the main areas that I would walk through my presentation today. So the World Health Organization calls on member states to expand access to equitable palliative care. And 2024 marks the 10th year anniversary of the resolution on strengthening of palliative care as a component of comprehensive care throughout the life course. This was the first ever standalone resolution on palliative care to improve access of palliative care as a component of health systems. And these are outlined here are the main actions that were mandated through this resolution, which include improving access to essential medicines, creating stronger policies, enhancing training for healthcare workers, support caregivers, and promote collaborations and partnerships to improve the quality of services among the countries. So why is it important that we advocate for the inclusion of palliative care into the emergency response in humanitarian settings? We are all aware of the global need for palliative care continues to grow as a result of the aging of populations, the rising burden of non-communicable diseases, and currently due to the ongoing escalation of global crisis. So 10 years after the resolution, there is still insufficient access to palliative care, as only 14% of people in need for palliative care can access it. Humanitarian crisis, which includes natural disasters such as earthquakes, public health emergencies as infectious outbreaks, overwhelm and collapse health systems. Humanitarian crises have a catastrophic impact, particularly on people living with NCDs, because their pre-existing conditions are exacerbated substantially due to the disruption of the health services. Provision of palliative care, therefore, to address critical symptoms such as pain, trauma, and ensure dignity and compassionate care, particularly for those in dire conditions, is not only a medical responsibility, but it's also an ethical necessity in these settings. So I will share in the next slides with you what have been some of the key activities that the World Health Organization is leading together with partners, focusing on the three main functions of the organization. So focusing on the normative function of producing guidelines, focusing on the country support, and particularly now, very importantly, on the leadership function. So talking about the normative function, WHO has produced a series of guidance documents to support integration of palliative care and non-communicable diseases into the emergency response. You can see here, and you're probably aware of the series of WHO integration of palliative care, and particularly the one that was launched in 2018 provides guidance on the integration of palliative care and symptom relief, providing practical consideration for policymakers and program managers. It provides triage guidelines to manage patients based on their condition, prognosis, and available resources, as well as outlining essential packages of palliative care services. Another important document that is recently in press is the operational manual on non-communicable diseases in humanitarian emergencies. This represents a tool to advocate for integrating non-communicable diseases and palliative care into the national health emergency response frameworks and humanitarian planning using all hazards approach. This tool provides recommendation to define and maintain essential service packages for non-communicable diseases, ensuring the continuity of care, including life-saving medications and specialized services such as dialysis and cancer care. This document provides recommendation as well to ensure financial preparedness and protection, to secure funding to support the essential non-communicable disease services, including the procurement of medication and medical supplies. So talking a little bit more about country support, I have been asked also to focus on the region of the Americas, but just wanted to provide some essential background on the work led on the emergency cluster by WHO. So WHO at the global and national levels ensures coordination among various health actors, including the governments, UN agencies, non-governmental organizations, and other humanitarian organizations. So WHO has been providing support to countries to achieve universal health coverage with the inclusion of palliative care, and more recently providing support to the delivery and implementation tool known as the SPIDI tool, to the request of member states that want to include palliative care in the national benefit packages for humanitarian response. Particularly as I've been asked to share with you some of the progress and challenges in the region of the Americas. So thanks to the collaboration from my colleagues from the Pan American Health Organization, PAHO, we understand their efforts to provide support to the governments, particularly of Panama and Colombia, to address the crisis in the region of the Darien. The Darien region is a selvatic area in the border between Panama and Colombia, a vast jungle territory where migrants face severe conditions due to the lack of access to emergency care and the adverse environmental conditions. But through the multi-stakeholder collaboration, including governments, cooperation agencies, civil society, and academia, articulated preparedness, response, and recovery strategies are being put in place to design to address the health needs of the migrants in the area. Also, the Pan American Health Organization is leading training and education activities through a sub-regional palliative care ECHO program, which is targeting 8 countries in the English-speaking Caribbean. And more recently, they have implemented a Latin American Emerging Palliative Care Leaders program with the aim to support future generations of palliative care leaders in the region, building competencies, focusing on palliative care advocacy and strategic planning. And I have shared previously with Erin some of the links to this document so you can review in more detail. And finally, aligning with the World Health Organization leadership function, I will summarize here in this slide some of the main resolutions and policy mandates that underscore the importance of incorporating palliative care and non-communicable disease services into the emergency preparedness and humanitarian response strategies to ensure that comprehensive, inclusive care for all populations affected by the crisis is provided. An example of this is the World Health Organization NCD Action Global Plan from 2013 to 2030 that calls for member states to ensure continuity of non-communicable services, availability of life-saving technologies and essential medicines in humanitarian crisis. And now this is a particularly important moment as we are preparing to the 4th high-level meeting on NCDs, which provides a critical platform to advocate for the integration of palliative care, cancer, and NCDs into the global humanitarian response. And as part of these activities on the way to 2030 and to the 2025 high-level meeting, there was a very important meeting at the beginning of the year in February, organized by the Kingdom of Denmark, and Moira had the opportunity to participate directly in this event and contribute to a WHO side event on palliative care and emergency settings. So momentum is building around the high-level technical meeting on NCDs, and participants to this meeting emphasized the urgent need for inclusive, comprehensive care frameworks that address both chronic diseases and palliative care in a humanitarian crisis. As an output of this meeting, and you can see below here, our team in headquarters have submitted to the Lancet Oncology this manuscript that calls for specific actions to to provide a standardized response with the inclusion of cancer care and palliative care in humanitarian crisis. And here to the left, you can see some of the specific actions that this global vision for action is recommending. So integrating palliative care into national preparedness and response plans to address specific needs of children with cancer, and strengthening workforce resilience, improving data collection and surveillance to inform decision-making process, foster multi-stakeholder collaboration, and particularly very important, advocating and financing for sustainable palliative care service provision. So just to finalize, I would like to leave with you some reflections. And I think that we are very conscious that the continued rise in conflicts and humanitarian crisis highlights the urgent need to protect the most vulnerable populations, including children and adults affected by cancer. Strengthening health systems to be resilient in the face of emergencies is crucial. This involves a focus on preparedness, ensuring that health providers are equipped with the necessary training and that the resources are mobilized effectively. Collaborative global action through multi-sectorial partnership between governments, international organizations, and humanitarian actors to develop adaptable care models are fundamental to ensure that no one in need for palliative care is left behind in total pain, even the most challenges of circumstances. So I thank you for your attention.
Roberta, thank you so much. You gave such a comprehensive overview and such a positive and encouraging report on what is happening from WHO level. And for me, it was especially interesting to see what is happening in Latin America and the Americas. And also, I share with you that passion for children. And so with that, any questions that you have, please, or comments, please put them in the chat and we'll address them when we come to the panel discussion. And so for now, I'm going to hand you over to Smriti Rana. And Smriti.
Thank you, Joan, and thank you, Palchis, for inviting me and giving me this opportunity to share a little bit about our work at Pallium India. Pallium India is also home to the Trivandrum Institute of Palliative Sciences, which is the WHO Collaborating Center. So thank you, and I'll just share my screen. And Joan, if you can tell me if my screen is visible.
It is. Thank you, Smriti.
Thank you. Thanks, Joan. So just to give you a little bit of a landscape picture of what palliative care access looks like in India. This is the density of palliative care centers, non-governmental palliative care centers in our country. And as you can see, we have a long way to go. And of the 526 centers, 44.5% of these centers are just in Kerala. And I'm sure everybody knows about the Kerala model, but as much as I'm proud of it, I also feel that it is a bit of a glass ceiling in some sense. And it's very important for us to not try and transfer the Kerala model, but to translate it into different settings. So this is just to give you a little bit of an overview of what it looks like in India. Coming to Pallium India, we are a 20-year-old NGO, and we work on a model of demonstration, education, and facilitation. And as I mentioned, we are a WHO collaborating center, and we also have consultative status with the Economic and Social Council of the United Nations. When it comes to demonstrate, we work out of Trivandrum. That is our headquarters. It's our flagship clinical services. And through there, what we really try to do is it's a proof of concept of what can be done in settings like ours. And within it, we have inpatient, outpatient, home care services, a telehealth service, as well as a vertical dedicated to rehabilitation of our patients and their families. And we do all of this with the active participation of the community. And the Astana Declaration talks about involving the community and the people in the design and the delivery of healthcare, and that is something that we completely advocate. Every year, this is just a little calculation we had done. Every year, our home care teams in Trivandrum alone travel the equivalent of going around the earth 4 times to provide services to our patients. Coming to the educate part of our model, we conduct in-person and virtual courses for doctors, nurses, allied healthcare professionals, and volunteers. And through this, we also design and create modules that are contextual and specific to the settings that we're serving. And oftentimes we go to different sites within the country and conduct the trainings there in their own settings. So this allows for ownership. It allows for us to also understand what their particular needs are and adapt the trainings to those needs. And with facilitation, what we really do is it's advocacy, it's supporting state governments as well as government bodies. And we work with both international, central government agencies, and very strongly with state governments and national health missions in order to implement the national program for palliative care. And we heavily rely on collaborations with other actors in palliative care in India and work with them and through them. And we provide knowledge and technical support to various organizations and institutions as required by them. When it comes to assisting with opioid access, one of the key features is that even though the Narcotics and Psychotropic Substances Act of India was amended in 2014 to improve access to opioids for pain relief, being a concurrent healthcare system, a lot of the state governments have not adopted it. So part of our job is to go and convene stakeholders in different states, take them through the new processes involved, not new now, it's been 10 years, but take them through the processes that have made access to opioids easier, because there's still a lot of paperwork and bureaucracy, and sometimes there is a misinterpretation of the law as it stands. So that is part of the facilitation work. As of 2023 December, this has been our impact. We have seen 25,000 plus patients, individual patients. We have worked with 76,000 plus family members and provided rehabilitation support to over 13,000 people. And through our training programs, 7,732 people have been directly trained by us. And through extrapolation, we have found that this is the number, 27 lakhs, those many patients that have been seen through the doctors that we have trained. And this impact is across 28 states and 6 union territories. I'll just tell you a little bit more about how that works. As of 2023 December, we have worked with various state departments for training and facilitation. And we have assisted with the catalyzation of over 200 centers. Opioid access facilitated means helping, assisting people get their recognized medical institution license in order to procure and dispense and prescribe opioids. We've conducted opioid availability workshops with those multi-stakeholder meetings, and various other activities that I won't go into detail, bearing in mind the time that we have on hand. But this has been our activity across India. I'll explain why there are those two bookmark photographs on this timeline. But just to take you through, my involvement with palliative care began a little after the year 2000, when my adoptive mother died of cancer, and she died very painfully. And at that time, there was no talk of palliative care, at least in the circles that I knew. And by 2003, we had experienced 5 more deaths in our immediate family. And along this timeline, these are the milestones that India has crossed. And we have palliative care being recognized as a subspecialty. The Indian National Program for Palliative Care was created in 2012, which we assisted in the creation of. 2014, which is 10 years ago, we had a huge victory in the sense that the Narcotic Drugs and Psychotropic Substances Act, which was actually a tremendous barrier to access to pain relief, was finally amended after 19 years of advocacy by civil society. And following that, we've had palliative care included in the Indian National Health Policy. It's been included in medical and nursing curriculums. While this is a lot of progress, why I have these two photographs on either side is to tell you that while my adoptive mom died of cancer in 2000, quite painfully, like I said, in 2023, my biological mom died of interstitial lung disease, and she needed oral morphine for her breathlessness. And in spite of being associated with the WHO Collaborating Center in the state of Uttar Pradesh, it was next to impossible to get access to immediate release oral morphine. And it was because of the privilege that I have of knowing who to call, knowing the law, recruiting a local doctor to write the prescription, and then having oral morphine sent from Kerala, which is about 1,952 kilometers away. That's how the oral morphine reached us. So while on paper we've made a lot of progress, the reality on the ground is not very encouraging, because if someone like me has difficulty accessing oral morphine, I don't know what it's like for people who don't have access to all the folks who work in this field. And finally, I will just end with this. We talk about the principle of balance a lot internationally, and the principle of balance really is the member states across the world are asked to abide by this principle of balance, where you prevent illicit and misuse of controlled substances, but you have to make them available for medical and scientific purposes. But usually this debate is centered around harm versus value, and it's restrictive versus enabling. You have people on both sides. And unfortunately, right now, access is mostly, it's governed by control and laws that control and regulate access. But what we really need to think about in this entire debate is who is at the center of it, this patient and the family, and that's where the balance lies. So just taking from the India experience, we have to really focus on the suffering of the individual and the family, and see what is it that they need, and do they have access to it, and what is hampering that access. Something can be available but not accessible, and we need to understand why that gap exists. And especially in low and middle income countries like ours, we have to focus on safe access, not just more access. And we have to do it through high quality data. And for that, we need to build evidence, we need to do research. And finally, everywhere, not just in Kerala, but even in Telangana, where Dr. Gayatri Palat and her team have done a tremendous job of bringing palliative care to 33 districts, everywhere where these models work, it has worked because there is a partnership between the government that uses its mighty, mighty infrastructure, professionals who know the science, and civil society who will do the advocacy. And unless these three are in lockstep, we're not going to make a lot of progress. So I will stop with that, and I'm happy to take any questions that might come up later. Thank you, Joan, and thank you, everyone.
Thank you so much, Smriti, for sharing not only the powerful journey of Pallium India and the impact it's made, but also your own personal journey, which is an indication of the progress. And I was fortunate enough to be there working with Dr. Raj in 2014 when the news of the amendment came through. And I don't think I've ever seen him at a loss for words, but then he said, I don't know what to say. I still remember that so clearly. And so with great thanks to Roberta and to Smriti, we go to the panel discussion where we're going to be joined by Dr. Catherine Pettis. And I'm sure that all of you know Catherine. And it was my pleasure to meet her in Geneva when the World Health Assembly resolution was passed. And I think that's when you began your advocacy journey, wasn't it, Catherine? And
it was, well, yeah, a little bit before, but with IHPC, yeah.
Yeah. That's the first time we met, and I still remember it so clearly, and it was such an incredible time of celebration. And so to have you here, and Father Rick, who was also part of developing the WHO resolution today with us, is such a privilege. And as you know, Catherine is the Senior Advocacy and Partnerships Director with the International Association of Hospice and Palliative Care, but she's also been an incredible support and advisor to the advocacy team at Palchase and helping us with writing a white paper on palliative care in humanitarian settings, where she has contributed so much. And so, Catherine, I'm going to ask you just for a while to speak a bit about, you developed the legal and ethical framework, and any other comments that you may have before we open it up for questions.
Thank you, Joan. Very exciting, very encouraging presentation from Roberta and from Smriti, of course, as usual, amazing work. The collaborations that we all have together, I think, is what makes advocacy work, because it's not an individual thing. It's always an institutional effort and an interinstitutional effort and an ongoing collaboration between all of us. I'm just going to say, because you asked me to talk a little bit about whether, what the barriers and the obstacles of integrating palliative care into humanitarian situations are. And also, what I can say from having kept an eye on this, a pretty close eye for the last 10 years or so, and it's exasperating because and maybe Roberta can say something about this as an insider at WHO, but even though we make some headway some of the time, the dominant narrative at WHO, and having Megan inside is going to really help too. The dominant narrative is really about ending premature mortality or reducing premature mortality and saving lives. It's just in every speech and most reports and resolutions. And when you dig a bit deeper into that dominant narrative, which is fantastic, of course, lives should be saved and premature mortality should be reduced. But it gets to a point where that is the only focus, then palliative care becomes a sign of contradiction to that. And it's something that it's really hard for policymakers to wrap their heads around. And of course, it deals with the D word, death and dying, and in common parlance, drugs. We really try to change that word to always using medications or analgesics or more technical language than drugs, which is such a problem because it's so stigmatized as a word, even though it's common parlance. So what we're really trying to do in essence is not turn the Titanic around, but really change the narrative and broaden the narrative through our advocacy so that it includes palliative care. And there has been, fortunately, a lot more attention now to aging. I mean, they can't ignore it now, the changing demographics in the world and the number of older people compared to the number of services and the number of trained professionals and the enormous gap between the development of chronic diseases. And so they've succeeded in reducing premature mortality in so many countries, such that they have this epidemic. I think that was the word I've heard so many times at WHO, associated with non-communicable diseases, or the burden of non-communicable diseases, comes with this narrative of reducing premature mortality. It's a side effect, which is an unintended consequence, which in many ways is it's wonderful that we've reduced premature mortality, but the evidence always shows that living longer is not necessarily living better, especially if you don't have palliative care. So we're doing more work on the aging issue, and I've been fortunate enough to spend enough time in Geneva at the Human Rights Council, where we now have some resolutions, the special rapporteurs on health and on freedom from torture and cruel and unusual punishment. And a couple of other rapporteurs have now included palliative care and access to medicines. So that's a way in to this narrative of premature mortality, because they can't ignore it. And that's enough for me for now, and we can change it. I've got plenty to say, but you don't need to hear all of it.
Oh, Catherine, you just frozen for a while. I was just about to say frozen.
No, it's good.
So, but thank you, Catherine, thank you for highlighting the issue of older persons as well, and premature aging, because that is a group that we often hear about the children in palliative in humanitarian settings, but not so much about the older persons. And I wondered, Roberta, if with all the work that you've done and the overview you gave us, and looking at the world as it is at the moment, the increase in conflict settings, the increase in climate change, the vast migration wherever we look in the world, the displaced persons, whether internally or externally. Is there anything that we could do to fast track getting palliative care into more deeply entrenched into the palliative care response? Because it feels to me it's almost like we're at emergency times.
Thank you very much, John. I think that with the implementation, as I mentioned, my area of expertise on childhood cancer, and particularly very fortunate to work with more than 70 countries now that are actively implementing the Global Initiative for Childhood Cancer. We have seen very successful examples, as we mentioned, the importance of people coming together, the importance of multi-sectorial collaboration at the local level, at the regional level, and at the global level. And we have seen, for instance, in the most recent conflicts, so with the support of the international network for Ukraine, we saw how communities came together, different stakeholders that are supporting childhood cancer, including patient organizations, survivors, the professional associations, and the health workers at the facilities coming together to support the transfer of children. So more than 1,000 children in the first months of the conflict were transferred. The support from neighboring countries, but also seeing the impact on neighboring countries where their health systems were overwhelmed, and how to support also the neighboring countries in providing care. More recently, also with the example in Gaza, unfortunately, a very difficult situation, but with the coordination, again, this is thanks to the existing networks that the Global Initiative for Childhood Cancer has created, with the awareness raised about the importance of childhood cancer and childhood cancer being a public health priority. So this has been very helpful. So strengthening partnerships, training and capacity building, all priority actions that constitute parts of the cure-all framework, which is the operational framework for the implementation of this initiative. But also very important, as we have mentioned before, the need to provide support to the health systems to make them resilient to the crisis. So ensuring pre-planning and ensuring the strengthening of supply chains, and also policy advocacy, as was very well said by Catherine. These are fundamental actions that need to be considered. And just to build upon what Catherine was mentioning, I think that in the past 2 years, we have been seeing a shift in the WHO narrative for non-communicable diseases. And this is mainly because we are working to meaningfully engage people living with NCDs and people living with cancer. So they are now being put at the center of the agenda. So we can work together with governments, with the organizations, to be able to really, really develop and shape people-centered care, particularly for cancer. So this is a commitment that our team in headquarters is now leading, and particularly very linked to the humanitarian crisis. Over to you.
Thank you, Roberta. Thank you so much. And leading on from that, Moira has given a question for you, really to follow on from what you said, saying with the cancer manifesto from the NCD high-level meeting on emergencies is excellent. Can we work with you to do the same for palliative care and be ready for the NCD high-level meeting next year? And that we could work together with you as Palchase.
Yeah, so absolutely. This is follow-up of the actions that I mentioned after the high-level meeting in Denmark. So currently, Moira, our team is working with the different organizations and the international leaders that participated in the manifesto. Is the output of another important meeting that took place in December last year, War on Cancer. So this is a group of people that put up together the strategy that was endorsed by our Director General, Dr. Tedros. But after the fourth high-level meeting, then a group of other stakeholders got together, many of them who participated in the manifesto. But the idea now is that we're working on a specific strategy to integrate different stakeholders. So absolutely, we will follow up to include Palchase, as we mentioned, the importance of inclusion of palliative care as the broader humanitarian response. And we are really glad for this space and for the opportunity to enhance the collaboration. Forward.
Thank you, Roberta, and thank you for highlighting Ukraine, because I think there are so many lessons we can learn from the not just the collaboration, but how Ukraine has continued to provide and educate in palliative care despite the ongoing war. So thank you for that. And Catherine, did you want to say something?
Yeah, I just wanted to say about Ukraine that one of the things we've been advocating for in terms of when we respond to agenda items at the World Health Assembly or the regional meetings with statements is that they need to have a strong health system in place prior to the emergency situation.
Yes.
And Ukraine was blessed with already having palliative care in their pillars. I remember interviewing the vice health minister from Ukraine a few years ago at the Europe WHO meeting in Rome. It must have been in 2018 or something. And I was so surprised because she said palliative care was one of the 3 pillars of their health policy already.
Yeah.
So, you know, when you asked me to do the legal and normative framework for the white paper of integrating palliative care into humanitarian situations, I was also looking at the documents and the soft law rather than the hard law, because none of it's hard law yet. It's high-level political declarations and things which mandate universal health coverage and primary care, which now, thanks to our advocacy earlier, includes palliative care. So that, but what happens with those high-level political declarations is they're not self-implementing. They have to be implemented in the countries. And that takes advocacy, and that takes civil society, and it takes the kinds of partnerships that everyone's been talking about. So the normative framework's there to include palliative care in humanitarian situations. What's not there yet is the advocacy teams and cores on the ground, which is one reason IHPC teaches advocacy, and we're
Sorry, I think it's
revamping our
might be
advocacy.
my internet that's unstable, and I keep on getting a frozen, Catherine.
Did everyone else freeze, or me,
Yeah,
or was
no,
it
I
me?
think, Joan, I think it's
It might
you.
be
Sorry.
mine. I think it might be
We can hear
mine.
Catherine very well,
Okay,
yes.
so, but
Yeah.
I'm done. That's it. Yeah.
I'm sorry. I'm in Jersey in the Channel Islands, so it should be perfect. But thank you. And thank you. And Smriti, I think sort of leading on from all of those, you know, I think that the need for palliative care is totally accepted in humanitarian settings. But are we being absolutely over optimistic to think it could be perfectly integrated? Well, not perfectly, but completely and comprehensively integrated? Or should we be focusing on just a couple of aspects like access to pain relief and communication, something like that? I don't know if you have any thoughts on that.
If I may zoom out a little bit and reframe, I mean, my answer to your question, Joan, is I don't think it's too ambitious, and I don't know if just focusing on one moving part really helps. I mean, there are so many things that need to move in tandem. One thing, though, I will sort of emphasize, taking from the Kerala model, not, being applicable to the rest of India, or, if you look at the global north and global south divide, I think we need to stop looking at templates. We need to look at, what are the strengths in each community? What works in the global north does not work in the global south. We know it. And so going back to these indicators and all of those, we need to understand that these have to work, they have to be scalable and contextual to who we're applying these indicators to. And I find that a lot of the time we're looking at the law, the policy, but in countries like ours, we can have a law and we can have a policy, and it'll be 10 years and that law is not implemented. So really, I think we need to step back and maybe look at the way we've been going about this. And in that way, I think it is going back to the drawing board. I know right now by saying this, I'm asking for a lot, but we know that certain things just do not work. Countries like, not just in India, but across the global south. So can we also have more representation of the people who are being affected and impacted at the decision-making table? Because that's, I'm going to say it, it's not happening. And let's start with that. So, I mean, I learned this from Catherine. If you don't have a seat at the table, you're on the menu. So I think we need to have a bigger table and a smaller menu. So, yeah.
Thank you, Smriti. I really do agree with you at that. I think that there are far too many sort of global north representatives speaking for the global picture and not enough from the global south.
And
And Rick, just thinking of you, you've been involved with the WHO resolution, and of course, one of the great powerhouses across the world are the faith organizations. And how do you see the faith organizations helping with palliative care in humanitarian settings?
Well, I mean, I think a couple things. I would add one bullet point to Roberta's great slides is that I think another one of the key elements of the resolution is globally, it said palliative care is the bio-psycho-social spiritual model of care. And if you're not doing all four of those domains, you're not doing palliative care. You might be doing pain relief, you might be doing hand holding or good psychotherapy, but unless you have all of them together, you're not doing palliative care. As we began in remembering, Dr. Twycross today, whose research was just so, important for documenting how we do pain relief. Quite honestly, we need better research, and we need to support our new researchers like Dr. Eve here on showing how palliative care is effective. We need, in my own field of spiritual care, we are just starting with trauma-informed spiritual care. We need better research. We need better implementation research. We need better theoretical research to do this. But that comes from listening, to the people that are affected by this. And so to get to your question, I think for many people of faith across, the theological spectrum, caring for those who are most marginalized is often a very important part. And so part of the education, and I think I so agree with Smriti, you can have the law, you can have the policy. For us at this webinar, we have to start with educating the community. I have to start with educating the pastors, the imams, the religious leaders, the traditional leaders, so that they don't hear palliative care of giving up. Can't we just hope for a miracle? So we need that community-based education of our families, of those affected, living with NCDs and cancer. We need better community care so that in the communities, it's not only a top-down, it's going to be a bottom-up revolution of healthcare.
Thank you, Rick. And I think, having recently done a bit of research into how people see the future of pediatric palliative care, this issue about the empowerment and the educating of the community came up again and again. And I think that we have to focus on that. So thank you so much. And I think there has been a question from Erin about how in countries which are already resource limited and, like many countries across Africa, Latin America, Asia, where a large number of migrants and refugees are ending up, how do we actually help them to cope, to build their health systems and strengthen them to cope with this influx of humanity that needs so much extra care? I don't know if anyone would like to respond to that.
So maybe I could just get started on this. So very, very important question, Erin. And I think that we have seen now with more ongoing crisis, the importance, as we mentioned, we prepare the health systems that are weakened. There are different moments on the humanitarian crisis phase that we can support through policy, but also through strategic planning. And that is what is very important as how to, bringing together the multi-sectorial territorial collaboration to generate those resources to be able to, and I mentioned recently, and Megan is here as well, and I know that she is more familiar with me with the support that the WHO is providing to countries upon request to help them shape their essential benefit packages. So there are ways to scale up their capacities to provide all services, inclusive of palliative care, very importantly, as this tool that was designed is to advance towards universal health coverage. So now the inclusion of essential health packages for humanitarian crisis is an area that can be strengthened with the support of the technical support provided by WHO, but with the collaboration, as I mentioned, the importance of bringing different stakeholders across the sectors in every country. So over.
Thank you. Thank you so much, Roberta. Would anyone else like to comment on that relevance? Father Rick worked in Africa for 25 years, so while he is at present in New York, he's very aware of the challenges there. Catherine.
I just wanted to say that it's important to take the long view, and we can't expect, I mean, Smriti talked about how long it took to get the law done in India, and it's been 10 years, but advocacy for such a big change, as I've been talking about and you've been talking about, we have to take the long view. And I've been reading a book on advocacy, public health advocacy for the anti-smoking campaigns by one of the leaders in Australia, and he was very insistent on that point too. It takes at least 30 years. So I think to be able to change a normative thing like smoking, like when you and I were growing up, Joan, if you remember, everybody used to smoke. And that's really different now. There's a whole thing about, so we've got to be patient and militant at the same time. And it's a tricky balance, but you just have to take the long view.
Yeah, I think that's an important point that you make, that this kind of advocacy does take a long time. But I think on the other hand, like going back to Smriti's thing about balance, is that on the other hand, we do have this increasing number of humanitarian emergencies.
Yeah.
And they're just going to continue to increase. It's not as though things are getting any better. They're not. So how do we up our advocacy for that as well? And thank you, Moira, for making that comment that we not only educate the communities, but we need to learn from the communities as well. And one of the communities that we haven't had a great deal of success with is that we tend to reach the palliative care communities, but we do struggle with the humanitarian response organizations. And while we have Catherine Richardson on the executive from Médecins Sans Frontières, and they have really been leading in integrating and educating on palliative care within their programs, that the humanitarian sector is often missing. And do you think it is something about palliative care that is putting them off, or just that they are overwhelmed with work, or any other reasons?
Well, I'm going to just jump right in. Because I'm at this webinar all the time, and we think the world understands palliative care. I also teach in the medical school, and my medical students, you say palliative care, and these are unbelievably bright young people. You say, what is palliative care? First response, giving up. So we still haven't, despite the resolution and despite all the work of these great pioneers and Dr. Twycross, we still haven't educated even our own health communities about palliative care.
You're right. Thank you, Rick. I totally agree. And Megan, you've had something to say in the comments. Would you like to speak to that? We have Megan Doherty here, who's now a consultant with WHO on palliative care.
Yeah, I mean, I think that we do have work to do to bring those emergency and humanitarian colleagues into this work. And I think hopefully maybe with my connection into WHO, we can look at increasing that. Like, how do we get those people at these meetings? Because I think there is interest and recognition that palliative care is important in these areas within WHO from the conversations that I've had, but they're not well aware of PalChase and the work that the organization is doing. And so I think we have potential to kind of establish more connection there.
Thank you, Megan. And Moira, I wonder if you would like to comment with your active work and with Gaza and so many other parts of the world. And you would you like to comment on what Megan has said or any part of the conversation?
Yeah, no, I think, I mean, I thanks to all our speakers. It's been a great conversation. And Roberta, yeah, we were together at that meeting. And I think there was great sense of togetherness from the emergency community and the palliative care community and cancer and diabetes, all of the NCD community. It was encouraging to see that agreement. I think the challenge is we all operate in different spheres, you know, and certainly if you look at, for example, the constituents of those who are on emergency missions, that's run in a separate place necessarily from where Roberta would sit or Megan would sit, and that's almost inevitable. So I think there's a lot more work to be done to get together. But I agree, Megan, when we've had the conversations, it's a very warm atmosphere, although I think we still have that balance on saving lives, alleviating suffering, and seeing that the two go together, that triage involves palliative care as well as it involves trauma surgery, for example, and making sure that's an holistic approach. So I think that it is a wonderful moment. The high-level meeting was exciting, and it's just really talking about how we can build on that and support one another. And because I think the moment is here, but there is still quite a gulf that we need to, and we need to listen to one another. It's not just the emergency teams that need to listen to us. We also need to listen to the realities of delivering care in some of these settings and be willing to learn as well as offer our suggestions. Thanks.
Thank you, Moira. And I think that is so important. And one thing I think we also need to realize while we talk about the time it takes is when we did the resolution 10 years ago, we actually didn't include anything about palliative care in humanitarian settings. It wasn't something that was in most of our radars, although the Humanitarian Health Ethics Group in Canada started very early on this. And so this movement is relatively new as well. But I do think that we need to look at how do we increase the pace of integration of the two. And so I want to say a very big thank you. Oh, Smriti, please.
Sorry, Joan, I just, I know we're running out of time, but I just want to mention one thing. And Moira was very much a part of this. When COVID hit, Moira and a group of people in India got together and created this tremendously important toolkit to, you know,
Yes.
to tackle or address COVID through a palliative care approach. And we got together and through advocacy, we went to different states in India. And we were able to get certain states who were so resistant to palliative care to actually issue government orders asking their healthcare workers to be trained with us. Now, one thing I just want to put on the table is that we are so used to talking the language of care and compassion. We also need to educate ourselves on the language of health economics.
Yes.
Not everybody hears what we are saying. And if we can convince them that, you know, by integrating palliative care, you will actually, this is the impact on the economies of care in other areas, that is a language. So I think, like we say in our communication classes, right, you have to speak the language of the person. And unfortunately, sometimes that means talking the language of economics. And that seems to be working in India, where we're now getting through the critical care medicine people and the pulmonologists and the cardiologists, because we're able to speak that language. So I just wanted to make that one point. Sorry. Thank you.
No, thank you, Smriti. Thank you for highlighting. And I think one positive issue is that we have some good examples of palliative care being integrated into humanitarian emergencies and settings. And we need to learn from them and build on that as well. So we're not starting from a zero level at the moment. We do have really good examples of this, and that is one of them. And also, I think the palliative care response during the floods in Kerala as well, Smriti. So let's all learn from that and build on, and maybe start thinking, how do we think differently? How do we think out of the box to take this forward? I don't know if, would our speakers like to just say a last word? I think we seem to have lost Roberta, but Smriti, is there something you would like to?
Nothing except thank you for this conversation. I mean, I learn so much every time I listen to each of you, and also from the audience questions, because, you know, I mean, the questions that people ask also highlights the challenges that folks are having across the globe, and it makes us think more innovatively. So really, thank you very much. This has been a huge learning experience for me as well. Thanks, Joan, and thanks.
Thank you, Smriti. It's been a joy to have you with us. And Catherine, would you like to give the final word?
Yeah, just to add my thanks and say that I am optimistic, even though it's slow, it's glacial, but it's still happening. And for instance, our delegation at the World Health Assembly this year, we had several statements which were joint constituent statements, so collaborating across a whole lot of other NGOs on palliative care and access to medicines in humanitarian situations. It just takes doing the work, and we're doing it. And Rick was on that delegation, as was Megan and a few other people. So we just keep doing the work, and Moira was on before.
Well, and I like, Catherine, what you said. It's, you know, one of my favorite, because I'm old, you know, favorite old sayings is think globally, act locally.
Locally,
You know, wherever you're at, you can do something. And I remember being at the last, you know, meeting, and like my best friend at that meeting were the group of anesthesiologists. I've never talked to anesthesiologists in my life, and they were totally behind what we were doing. We became best friends, you know, educating them more on, for me, the spiritual, you know, domain of palliative care. But it's like, you know, yes, we need PalChase to think globally, but wherever, I mean, we had 35 people on this, you know, act locally, you know, continue, and thank you, Moira, to educate communities, but learn and listen to our communities of what they want and need.
Yeah, thank you so much. And thank you everyone for attending. Thank you, Erin, for all the technology. Thank you especially to our speakers, all of those who've contributed actively either in the chat or in discussion. And we will be, this has been recorded and will be put up on our website in due time. And then tomorrow morning at 8 o'clock UK time, we will have a repeat of this particular webinar. And we look forward to seeing another group of people attending. And so, Erin, what are the dates of the next webinar? Sorry, I haven't written those down. In January will be our next webinar. And if there are any subjects that you would like us to cover, please do contact us through info@palchase.org. And if you're not a member of PalChase, well, membership is free. So do join up, and you can be part of this movement, taking palliative care in humanitarian settings forward. And
yeah, we'll be meeting in January. Yeah, no problem. January 23rd and 22nd and 23rd. We usually do the third week every quarter.
Yeah, thank you so much. And thank you for all the comments that have been made in the chat, and those will be recorded as well. And so it just remains for me to say, enjoy the rest of your day, whether it's the whole day or whether it's in the evening. And we look forward to seeing you as members or active members of the working groups, if you would so like to join, and just to be part of this movement to get palliative care where it's so needed in humanitarian settings. So thank you, everyone.
Thank you.
Thank you, everyone.